So today's expert panel is all about helping dental practices get faster, improve cash flow, and protect profitability through stronger credentialing, insurance, and collection strategies. Because honestly, many practices are working incredibly hard to deliver exceptional patient care, but revenue challenges often happen behind the scenes. Credentialing delays, insurance participation decisions, claim denials, aging receivables, collection bottlenecks. These issues can quietly impact profitability long before practice owners realize how much they're costing the business. So today's conversation is really about understanding where those challenges originate, how to address them proactively, and what practices can do to create a stronger financial foundation moving forward. So before we begin today's event, it's proudly sponsored by Equa Marketing. Equa Marketing was founded by Naren Aruraja, who is also the founder of the Thriving Dentist Expert Panel Series. So for nearly 20 years, Equa has specialized in helping dental practices grow through customized digital marketing strategies designed specifically for healthcare providers. Now, the services include website development, SEO optimization, digital advertising, call tracking, online visibility strategy, and long-term growth consulting. So a huge thank you to the Equa team for supporting today's discussion. So one thing we're seeing across the dental industry right now is that practices are working harder than ever to maintain profitability. Rising costs, insurance pressures, staffing challenges, and reimbursement concerns are forcing owners to look more closely at every part of the revenue cycle. So that's why today's discussion is so important, because improving profitability isn't always about producing more dentistry. Sometimes it's about improving the systems that help you collect what you've already earned. So, throughout today's discussion, we'll be talking about credentialing challenges, insurance participation strategy, claim denials, collections, accounts receivables, and practical ways practices can strengthen cash flow while protecting long-term profitability. So, first, we're joined by Bree Richardson. Bree is a dental insurance specialist, trainer, and speaker who helps dental practices improve collections, reduce AR, and get paid faster. She is the founder of Elevate My Practice, where she works closely with front office teams on everything from insurance verification and clean claims to denials and patient collections. So what I really love about Bree's approach is that she makes a topic most practices find stressful and confusing actually feel practical and manageable. So she brings a lot of hands-on experience and real-world insight into what's actually happening inside dental practices today when it comes to billing, insurance, and profitability. Bree, we're so happy to have you with us today.
Thank you for having me. I'm so excited to be here.
Of course. And joining us today is Tracy Guzma. Tracy is the founder and CEO of Dental Credential and has spent more than 25 years helping dental practices navigate the constantly changing world of insurance and credentialing. So she's worked with dentists and teams across the country on improving profitability, negotiating smarter insurance contracts, strengthening operations, and helping practices better understand the financial side of the business. So, what makes Tracy's perspective especially valuable is how clearly she connects operational decisions to long-term practice growth and stability. She brings a huge amount of industry knowledge and practical experience to today's conversation. Tracy, thank you so much for being here with us today.
Thank you so much for having me. I'm thrilled to be here.
All right. So before we jump into the discussion, I also want to mention that if you stay with us until the end, we'll be sharing a complimentary growth strategy opportunity designed specifically for dental practice owners looking to strengthen growth and profitability. So we'll share more details on that shortly. And for everyone joining us live today, if a question comes to mind as we're talking, feel free, drop it in the chat. We'll do our very best to answer as many questions as possible during our Q&A session. All right, so let's get into the main discussion. So, Bree, I would love to start at the beginning of the revenue cycle. So, before a claim is ever submitted, where does revenue leakage most commonly start inside a dental front office?
Well, before the claim is submitted, the patient has had the treatment and now they're at the front desk. The revenue leakage really starts there if the patient isn't paying their full portion. And if you trace that back to the origin, that really starts at the insurance breakdown. If your insurance breakdown is really good and thorough and your whole team knows how to use it, then you can estimate copays and foresee denials so that when you're at the date of service and the patient is checking out, they're paying their full portion. All of us know that if you don't collect the patient's full portion, you're starting off at a loss. Not just financially, although that's a huge part of it, but also the admin burden that comes with it is extremely big compared to if you get these ducks in a row in the beginning and you can be prepared right from the jump. Some
Mhm.
other places that it can kind of break down before the claim pays is something as simple as not having an insurance card on file. It's really easy to enter all these details in the computer and then type one little digit wrong, and you don't really have a way to verify which one it was. So sometimes it will reject, your clearinghouse will say they're not active. If you don't have that actual document to go back and say, let me just check and make sure our data is right, because if you don't, now you're just thinking, okay, the claim has rejected and the patient isn't going to have this payment or whatever it may be. Not having an insurance card on file creates all of these little tiny problems down the line that could have been solved right then. And honestly, I think that's really it. If you can get the insurance breakdown and really nail that part, it's going to solve so many of your payment delays. It's going to really revolutionize your practice if this isn't something that you've implemented yet.
Mhm. All right. So, speaking of which, one area that creates significant financial challenges is credentialing. So, Tracy, how does delayed credentialing impact a practice's cash flow and collections?
Well, essentially, right, if we're out of network, if the patient is expecting us to be in network, now we have a disconnect with the patient. So
Mhm.
when we think about our practice and we think about like financially, like what we need to do with the credentialing, we look at it and say, okay, number one, you need to do the credentialing as soon as you possibly can. Because if that, whether it's an associate, whether you're a new owner when you're transitioning, whether you're in a partnership, whatever it may be, if you are not credentialed, you are now out of network. So now what
Mhm.
happens? Do we not see patients? I don't know that that's the best option, right? Because now we've just jammed up our schedule, or we have to constantly keep pushing patients out, which really at the end then sacrifices patient care. And so we want to make sure that, like I said, that credentialing is done obviously as soon as we can. So if we're out of network, now the patient could be frustrated. We could have to schedule out. And here's the other thing. If we had treatment planned as an in-network, and this is where Bree and I are right on the same page. If we treatment planned as an in-network dentist, and this is what the patient is now expected to pay, well, what happens when we send that claim in as out of network, right?
Mhm.
It's probably not going to be the same thing. So Now we have to go back to the patient. We have to adjust the claim, which then we could be talking about thousands of dollars in write-offs for something that could have been prevented. So there are times that credentialing cannot be done, okay, because of, for whatever reason, the associate comes in, it's only been a couple of weeks. There can be reasons and situations, and we as practices can work through that. But the key is we don't want to sit on our, hands and not do anything. And now this associate is starting, and we're like, well, we don't have patients to put in your book because we only can put our in-network ones, especially if we're a heavy PPO practice, right? Where we're 80% PPO, 90% PPO. That can cause a lot of disturbance within the practice by having an uncredentialed provider if we're not prepared for it. So financially, it can be a huge impact on the practice because we don't have claims functioning as they should. We don't have treatment plan estimates that are correct. And it's a possibility that we're going to have to do a lot of write-offs on the back end in order to make things okay for the patient.
Yeah. All right. So now this also brings us to billing visibility and denial management. So, Bree, most dentist owners delegate billing entirely. So what do they typically not know about their denial patterns until the damage is already done?
That's a great question. So I run across this a lot when I'm training practices that dentists don't typically know what they're writing off. So I think that something that's really surprising for me as a biller is when I learned that 75% of denials are never appealed. And I think that owners sometimes need to know, first of all, there are some denials that are legitimate and you could have seen coming had you had the insurance breakdown side nailed down. But there are also a lot of denials that they just need more documentation. So let's fix that problem, but also train your team which ones are which. So a denial for a red tape restriction of the plan, like frequency, missing tooth clause, replacement rule, you can't appeal that. There's no point. Unless they're wrong, of course. If they really denied incorrectly, that's different. But if they denied for there's not enough attachment loss from the CEJ for SRPs, or they're denying this crown buildup as inclusive. A lot of the inclusive crown buildups, if you say that what they're actually for, which is crown retention, and then sometimes, like with Cigna, if you give them the seat date, a lot of times you can actually get those overturned or get them paid the first time by just putting it on there the first time. Also, with things like crowns, if they say it's not medically necessary because A, B, and C, not enough tooth structure was missing, not enough this or that. And sometimes the team will actually, they do know, well, I can appeal this, and they'll try. And sometimes the appeal doesn't actually process. So one of the things that one of my main clients for training is someone that used to outsource and now they bring training in-house. A lot of times why this happens is even some billing companies will have these rules, I guess, that they will only appeal 3 times. Well, I think most billers know this, but some of them that are newer maybe don't. And I've heard this story so many times, that's why I'm bringing it up. It's almost always around a $10,000 treatment, and the denial it keeps coming, but it says the patient owes 0, and it's because the claim really didn't process. The patient doesn't owe 0, even if it's denied. And then the biller wrote it off because they did their 3 appeals and it didn't work. So they're following the EOB. I think it's really important for your in-house team and the doctors to kind of know, whether you outsource or not, look at those adjustments, especially the biggest ones every month, and just double check and make sure everything is accurate, because you might be finding stuff that honestly someone just didn't know. And it's really hard for us to hold our teams to things that we never trained them on. A lot of billers are self-taught and they need more formal training. Another thing is, make sure, like I said, make sure they know what they can appeal, and when they appeal, how to appeal, because a lot of appeals, you just send it back and it denies as a duplicate, and you can go on Vine and you can attach it again and resend it. So hopefully it won't, and sometimes it doesn't, but a lot of times it still does. So in that case, let's look at the EOB and see if there's some clues. Or if it's denied once as a duplicate, we're not going to try the same thing over and over. We're going to mail it or fax it, or we're going to call and say, hey, what's your process for appeals? Well, Aetna, Delta, they have these forms that you can fill out and send with the appeal. Cigna, you can actually, and Delta, and a couple of them, you can send the appeal online. A lot of them have a completely different address, fax number, or email. Read that fine print on the EOB and make sure all of the fruit of your labor is worth it and that you don't have to keep redoing the same work over and over.
That's really, really interesting. So Tracy, how do you evaluate whether an insurance contract still makes financial sense for practice today?
Oh, that's a great question too. Here's the thing. As dental office back in the day, okay, what used to happen with contracts is literally salespeople would walk into the office. They would walk into the office, they would give us a pretty fee schedule, and they would say, look, we'll put you in network with this. And we go, okay. And we kind of forget about it. And all of a sudden, we have contracts stacked upon stacked upon stacked. So the question becomes, do you need all those contracts? And what served us before and what made sense to us before might not make sense to us today. People talk about their insurance is confusing. So when I was even a practice manager as to what I am now, I have learned 150% more than I ever knew as a practice manager when it came to insurance. And there's still things about it. It's ever changing. There's things that I would say today in this podcast that possibly 3 years are going to be completely different. So we have to look at our contracts as an office and also look at all the changes that are going on in the insurance world to figure out if they still financially make sense for us. If we're being paid $24 for a periodic exam, you're running around on a hamster wheel. So, and sometimes we can talk about volume of patients. Volume doesn't always that doesn't always mean profitability. It just means we're running around on a hamster wheel. So you have to strategically look at your contracts. And when I work with offices and coach them, one of the biggest things is I'm like, insurance is not something we just set and forget about it. You can't operate that way because the contracts keep changing at times and relationships change. It's been a huge year. Well, 2025 was a huge year, and there was more announcements that just came out the other day. All of these insurance companies are partnering with each other. Call them an umbrella network, call it a shared network arrangement, call it a lease network, a third party. There's lots of difference, and we could dive into, oh, here's all the details because each of them means something slightly different. But for our purposes, if we think about our contracts, we can have competing contracts. You're all sitting there saying, what's it, Tracy? What does that mean? It means that we can actually have fee schedules, lower fee schedules, get in the way of other fee schedules because we're contracted too heavily across the board. You do not need to be in every single contract that is out there. There are ways to increase your participation and your patient reach, and you can trim your insurance contracts. So when I work with offices, my goal is how do I trim your contracts, get you higher allowables with the same patient reach? Is that it? And many times it's possible. People look at me like I'm a crazy person. No, that's possible. It's just you have to know how the insurance companies all work together and they all fit like a puzzle. So you have to make sure that you are not in contracts that are hurting you because you haven't looked at what that contract means and how it fits into your particular insurance plans.
Perfect. What numbers do you think that practice owners should actually be reviewing regularly?
As far as with their insurance contracts or just overall? Like, are you saying with
Overall.
insurance? Okay.
Overall.
Well, obviously, we want to be looking at our collections. We want to be looking at our write-offs. Though, our gross production is certainly important. That's a whole different conversation. Okay. But our gross production, if we're in insurance-based practice, is unattainable. You cannot collect your gross production. But then you need to monitor your write-offs. And you need to have a gauge for that of, okay, I know that my write-offs are 20% or 25%. Well, then the next year they went up to 30%. And then the next year they went up to 35%. I would want to know why that is happening. Sometimes because of we're increasing our fees and the insurance companies are not keeping up with that, right? Your write-offs may increase. But that is a gauge to be able for you as a practice owner to say, okay, I know where my adjustments are at, because that to me, then you can start looking at some of your insurance contracts and we can start drilling into these are your low paying ones. This is what's driving your numbers down. So there's a lot of different ways that you can do that. People get afraid for some reason. I don't know why this is, but I'd like to put this out there. You need to be billing your UCRs for your office to the insurance companies. I run into practices that are billing their allowables, and that's not going to help you. That's actually going to hurt you in a lot of different ways. I'll touch on that probably a little later because I'm probably going over my time. But that is a key thing to do. So the write-off percentage is important. That is a number that we can work with because the data doesn't lie. Then we're not making decisions based on feelings. We're making it like, oh, I feel that this insurance company doesn't pay me enough. No, we can actually see the write-offs so that we're able to make a good educated decision.
That's really, really interesting. I mean, always not going with your gut feeling. So Bree, when a denial comes in, right, how do you decide whether the recovery value justifies the cost and time required to appeal it?
Oh, it's worth it, 100%. We don't take denials laying down ever. If it's something we can appeal. Now, like I said before, if it's a red tape restriction of the plan that they're just not going to pay for it, don't appeal any of those. They're not worth it unless they're wrong. But anything where they say that this was denied because of insufficient tooth structure is missing, there's not enough millimeters from the CEJ, not enough attachment loss, this isn't severe enough, this wasn't enough chair time, that, this, and that. Anything that they say on a denial, as first of all, a lot of times it's not actually true. The problem is that your documentation just didn't dispute that. So what do? We make our documentation, as long as it's accurate and true, dispute it and use their language back to them to say why it was actually required. Because honestly, they're just checking boxes. Insurance is not actually that complicated. It is a list of check boxes. And if we know what the check boxes are, we can give them what they want. So let me give you an example that's kind of off the wall. Bridge claims sometimes need perio charting. Why? Because they're not sure if the bridge is going to last long enough for them to justify paying it. So let's get in front of that. Instead of waiting for them to ask for a perio charting, why don't we just send it the first time? Is that an extra 5 seconds? Absolutely. But it's definitely going to save you time later if they're going to ask for it. So especially if the bridge is anterior and especially if the patient has periodontal disease, give it all to them the first time. But I think every single denial is worth an appeal as long as it's something that you can appeal and get overturned. And honestly, I mean, with my team of insurance aging sharks, like we will fight to the death for these dumb claims denying. I think there is no situation that it's not worth it ever. I mean, if they are maxed out and they're not going to pay, I mean, I even still deny those because I don't want the denial to say it's because we're missing perio charting or something. Okay, that's my soapbox for that. I get really excited.
Oh man, I'm loving all these answers both of you are giving today. I mean, it's very informative. It's actually really, really interesting. Let's get back to Tracy. So, Tracy, when you first review a practice's insurance setup, what are the biggest red flags you look for?
Couple of big things. Probably the biggest thing that I look for is offices that don't know where their contracts are.
Mhm.
They don't know what their contracts are. They don't know what fee schedule goes with what insurance company. So when those type of situations happen, now it's messy. It's
Mhm.
messy for the office. It's messy for patients because half the time we might not even be giving them accurate estimates because we're not sure what fee schedule to base it off of. So the one thing that I would encourage offices to do is create a map. Create a map that shows you here's Humana. I'm just going to pick them out. Here's my insurance company. Okay. And what type of contract do I have with them? Do I have a contract that is directly through Humana? Like I've signed a contract one-on-one with Humana? Or is it another fee schedule that is coming in from one of Humana's partners, we'll call them? Okay. So is it all of a sudden Cigna's fee schedule? Because now we're in network with Cigna too. And Cigna's fee schedule is pushed over to Humana. And I get offices telling me all the time, we're out of network with Humana. I'm like, not anymore, because all of a sudden you're now in network because of other things going on with other contracts. So, big red flag is nobody knows what's going on. And if nobody knows what's going on, there's no way that you're going to be able to negotiate because you don't know what's going on. You don't know where your contracts are, and you don't know how it affects the financial health of the practice. It's hard to even make decisions because again, you don't know what fee schedule is going where. And then we can start talking about percentage of patients, right? So if we look at it and say, well, wow, 60% of our patient base is through Humana. Well, to me, that's a really important contract because that means that 60% of our money coming in of our revenue cycle is coming from that one source. If I
Mhm.
don't even know what fee schedule to use for my Humana patients, then it's like mass confusion all over the place. So, and again, then we start talking about, like I hit on before, we can have too many contracts in too many places that are causing competition. And that's probably the biggest thing that I see with practices is that I get calls all the time that are like, I have this awesome fee schedule. How come I never get it? Well, you got another contract that's in the way. Or I wasn't in network with this. Why am I not in network? So, and actually, I feel like it could just be me. Again, I've been doing this 25 years. I feel like the insurance companies are getting more confusing. There's more networks, there's more relationships. A lot of insurances are creating umbrellas underneath themselves. So there's your fee schedule could move all over the place if you're not paying attention to it. And if we have a poor fee schedule that is going everywhere financially, that is like one of the worst things that can happen because that drives all your net production. That's going to drive your net production down, your collections down, everything down because we have this poor fee schedule that's in the way of potentially other wonderful fee schedules. So,
Mhm.
at the end of the day, would we all like to be fee for service? Of course we would. I mean, that's everybody would. But if we can't, because of patient demographics, what's going on in our community, what's going on in our practice, like sometimes we just don't have that option, then make sure we're at least smart about the contracts we take. And so that we're getting maximum allowables from the insurance companies for the patients that we're seeing.
Mhm. Yeah, we've got a few messages from a few people on the chat. Devon Banks says, "Hey Bree,
Hey, girl.
And then what else do we got? Yeah. Devon Banks also said to one of the questions, one of the answers you gave, he said, she said, kitchen sink method.
Yes, send it all.
Yeah. So if you guys have any questions, please do uh send into the chat, and our panelists would be really, really happy to answer them. Yeah. All right. So honestly, guys, there have already been so many valuable insights shared throughout today's discussion, especially around how practices can, unknowingly lose revenue through credentialing gaps, denial, patterns, outdated systems, and operational blind spots. And I think one thing that's becoming very clear is that many practice owners are so busy running the clinical and operational side of the business that they rarely have the time to step back and fully evaluate where, opportunities may be slipping through the cracks. So before we continue into the second half of today's discussion, I want to take a few minutes to highlight a special opportunity from our sponsor, that is Equa Marketing. So as a thank you for registering today, and joining us here today, Equa is offering every attendee a complimentary marketing strategy meeting. So one thing that really stands out about Equa's approach is that they don't believe in generic advice. So before your meeting even takes place, their team actually spends time researching your practice ahead of time. So they look into things like, your website performance, online visibility, local competition, SEO opportunities, patient search behavior, conversion gaps, and areas where your practice may already be losing potential revenue or new patient opportunities online. So by the time you actually sit down with them, the conversation is already personalized specifically to your practice. So you'll receive practical insights around improving visibility, attracting higher quality patients, strengthening online conversions, and identifying opportunities for long-term growth. And honestly, even practices that feel they're doing fairly well online often uncover gaps and opportunities they didn't realize existed. So if today's discussion has sparked any thoughts around, improving systems, increasing profitability, strengthening visibility, or creating a healthier long-term growth strategy for your practice, I definitely encourage you to take advantage of this complimentary session. So all you have to do is just simply scan the QR code on the screen to schedule your complimentary marketing strategy meeting with the Equa team. And if it's easier, you can also check the chat because Team has dropped the scheduling link there as well. All right, so let's get back to it. Bree, now walk us through what actually happens during EOB review when a team member lacks training to compare the contracted rate against what was paid.
When they lack training, what happens? Well, that's a mixed bag of what could happen. I can tell you that a lot of times what happens is there's too much of a write-off,
Mm-hmm.
usually. So if a team member is not trained and they're looking at an EOB, the first thing that gets missed is obviously if there's something that they could have denied, and I mean they could have appealed and they didn't realize it. Sometimes it doesn't get appealed and they just think, oh, okay, they didn't cover it, and they might write it off. Another thing that happens is sometimes there's this misunderstanding about what the patient owes. The patient doesn't owe what you taught them, what you told them that they were going to owe if you were wrong. They actually owe their copay or their co-insurance, regardless of if you were right or wrong in the beginning and at the treatment planning stage. So most of the time, I mean, EOBs are not infallible, but most of the time they are correct. So we need to follow the EOB as far as what the contracted rate is for what the write-off is. And if the patient has a portion, then they have a portion, because the dentist contract says something along the lines of the patient still has to pay their portion. They're not going to write it all off routinely, especially, and that's okay. So if a team is not trained, usually they're potentially accidentally writing off too much and not appealing enough.
Very interesting. So one thing that often gets overlooked is how fee schedules impact everything downstream. Tracy, when a practice's fee schedule hasn't been reviewed in years, how does this impact insurance reimbursements?
Oh, lots of ways, Angie. So that's a great question. So a couple of things with that. Insurance companies base their reimbursements, probably not completely, but they do, on what we as offices are sending in. Okay. So they will determine what an allowable will be based on data. Again, we're back on data. So a couple of things. Number one, if you're submitting the allowable, we kind of already talked about that, that'll hurt you, because what happens is the insurance companies, then you actually drive things down for everybody else around you. So it is very important for all of us to be sending in our UCRs and then updating those UCRs annually. So why do we update the UCRs? Why do we update our master fee schedule? Well, number one, you have to make sure that your allowable is at your UCR is not underneath your allowable. I've seen that happen where all of a sudden they have their master fee schedule set at $30 for, we'll say, fluoride, but fluoride will be reimbursed under a certain contract at $35. Well, you're leaving $5 on the table every single time you do that. Okay. And number two is what happens with our fee schedules too. That also plays into how we can negotiate with insurance contracts. If we have our fee schedule set at a certain amount and we never increase it, and then we go back to the insurance companies and say, hey, we want to negotiate, the insurance companies are going to go, well, it looks like we pay you pretty well. We're paying you 90% of your master fee schedule. So let's just say I'm going to use an easy number, pro fee of $100. Okay. And we sit there and we say, okay, after this pro fee for $100, we send it in and we get reimbursed at $90. Okay. That's a 10% write-off. If we don't take that $100 and continue to increase that, the insurance company is going to be like, 10%, you're lucky that you're getting 90%. And you would say, well, wait a minute, but I haven't increased my fees in 5 years. They don't care. So you need to make sure that we're doing this annually. And here's the other thing. If you think that you hold your fees and then in 5 years, you're going to do this huge jump and all the insurance companies are going to go, great, we're going to bring you all the way up to where we think you could be, that doesn't happen either. So you hurt yourself as, and my dad was a dentist. I've been a practice manager too for a lot of years. And we think sometimes like, oh, we're going to hold our fees for our patients so that our patients aren't going to notice that type of thing. Well, now it's 3 years later and we talk about you having to do a fee increase. That's a whole lot more noticeable because now you got to do a big old jump to get us where we need to be, where if every year you're doing it and keeping up on it, it's not nearly as dramatic for the patients and you're getting paid that's following inflation and following everything else. We keep our fees the same. Everything else has gone up, right? In how many years? So the insurance companies, like I said, there's data all over the place, right? This is only one component of it, but it's very important that our UCRs are going in and that we're maintaining our fee schedules where they need to be. So
Mhm.
there's resources that are out there that you can go and get a fee schedule that will show you breakdowns by percentile, by zip code, so that you can see like where you are in comparison to other dentists, practitioners in your area.
Perfect. Getting back to Bree. So Bree, during the daily huddle, what specific check tied to insurance eligibility most consistently prevents a claim submission problem later that same day?
During the huddle, I think that this should happen before the huddle, like the day before. When you're looking through your software, whatever it is, a lot of people use something like Vine or similar, where it gives them a list of patients that are showing eligible or ineligible or needs attention or something like that. So before the huddle, I think it's really important that that information is already gathered. And then during the huddle, it's like, hey, we need these 4 people. We definitely need to update their insurance because it came back as not active. And hopefully, also, this has already been attempted to gather from them. And this is sort of the last resort now that they're coming in. But anyone that's not eligible, any insurance breakdown by this point of the team huddle, it should already be done. It should already be uploaded into the computer. And you are kind of at the last, like, okay, we have to get it. Otherwise, this patient's paying in full today. And that cannot happen at checkout. That has to happen at check-in. And a lot of softwares, they have really easy ways for you to reach out to the patient and ask to update their insurance information. So if you're not using this, if you are still calling for all this information, please look into what you already have and what you already pay for, because they usually are a pretty basic tier that's included, and they can like text out a form or like the text to verify thing, and they can ask for the patient's information ahead of time, where you're getting it electronically and verifying it quickly instead of calling, waiting for them to answer. They never answer. Calling them again, and you can really automate a lot of this stuff. So if you're not using that now, look at the software that you have for texting already and the software that you have for your claim submission, and see if it's a function that might just not be turned on. I know when we do training, this is something that I always look at. Is your software that you already pay for going ahead and looking at your schedule to take some of this burden off your admin team? I will tell you 95% of the time they have it, it's not turned on. So check your
Mhm.
settings.
Yeah. What do you think that every front desk team could be discussing or should be discussing each morning?
Did you say month or morning? Sorry.
Morning, each morning.
Morning. The front desk team, I think patient balances and insurance changes are a big thing. Maybe places that, because front desk, they do more than just revenue cycle. I think that places that people could potentially stay for same day treatment is a really good thing to discuss. But anything that affects the doctor's cash flow, I think eyes on that is the primary focus for a team meeting. And then just kind of a fun thing, like something encouraging and motivating for the team. And then how close you are to your goals, and celebrating your wins together as a team is so motivating. You might have a goal, and if it only comes up once at the team meeting every month, one time, eyes aren't on it. It's not front top of mind. And especially if you have some type of incentive for reaching the goal, bringing it up every day and kind of keeping everybody's head in the game is really, really fun. And then it's kind of like a wave pool or a world. What's it called? Wave pool. When you're in the pool with your cousins and everybody's going around in a circle and you get the current up, when one cousin gets tired, it carries the rest of the cousins. It's just like your team. When you're all working toward the same goal and one of you kind of gets tired, the strength of the team will carry you and get you there.
Mm-hmm. That's really, really interesting. It's perfect answer. We have a question from Sam. Sam, we will be answering your question during the Q&A session. All right. So Tracy, when a practice is never reviewed, its insurance contract strategically, where do you begin?
We create a map. we create an insurance map,
Mhm.
and we start going through that insurance map and figuring out where our contracts are. And how do we do that? We call the insurance companies. We don't check websites because they could be correct, they might not be correct.
Mhm.
And the question is, when you call the insurance companies, like if you literally have no idea where your contracts are and where you are with what, I create a list of the top 15 insurance companies in your area, okay? All of the big ones. And you're going to start calling those insurance companies saying, "Hi, this is Tracy from blah, 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 ABC Dental. And I am calling to see how we are showing in network with you. Do you
Mm.
show us with a direct contract? What fee schedule are you using? Do you show us through a leased partnership?" They'll be able to guide you. And sometimes you might get an answer you don't really want to get, where they'll say, "We have one contract, two contract, three contracts, and they're literally stacked one right after the other for your office." You check every doctor in your practice, so not just one doctor, because every doctor, if that is your goal, right? Some offices have different participation based on specialist or whatnot. But if your goal is the same insurance participation all the way across the board, you check each doctor and you build this map. And this map will tell you at the end of the day, here's where my contracts are, and here's where the fee schedule, what fee schedule is being applied to what insurance company. And then you're able to look at that and see, okay, here's my starting point. This is everything we're contracted with. And this is the fee schedules that are being used by insurance company. Then from there, you can gather the fee schedules, like gather all the fee schedules for your contracts. You should know when you can renegotiate your contracts. Many of our contracts have things in them that you can negotiate once a year. There's a couple that are once a year. Otherwise, it's every 24 months. There are some that do not negotiate, but you need to know if your contract allows that. Because if it does and you don't ask, they're not going to give you anything just because. So this is our starting point. Again, knowing where our contracts are and building that map. That is kind of the key, because it's like it's like all of our information. If we don't have all that information put together, it's very hard to make the decisions to say which way are we going to go, because we don't have anything to start with. So that would be the very first thing that I would recommend. And if you feel that you get a strange answer from somebody on the phone, you call back and you ask the same questions and see if you get the same answers, because sometimes you will not. So but again, that's the best way to start,
Mhm.
is by developing that map.
A map. That's absolutely amazing. I mean, a map can actually help basically everything that is going on, right?
Yeah.
Uh, yeah, for sure. So, Bree, let's get back to you. So, what is the one number a dentist owner should pull from their accounts receivable report this week that will tell them immediately whether their billing process is underperforming?
Oh man, one number for a numbers nerd. I have to pick one. Okay, I got it. Insurance aging under 30 days old. If your AR report, now run this over a penny because you don't want all the credits throwing it off. But if you run your aging report, so it's filtering out the credits, the percentage that's under 30 days old, if 75% is less than 30 days old, you are firing on all cylinders, most likely. If not 75% is under 30 days old, that's something to look at. Why? Do you have a lot of deadweight accounts? Are your books clean? Are your patients not paying enough on the front end? Probably not. Are you do you have a collection protocol so that your team knows what to do when the insurance pays and there's still a balance, is everyone on the team doing the same thing, or are they all doing something different? Are you using text statements? There's all these things that can come from that. But if your number is 75% under 30, you're probably good. If it's way off than that, hey, we should probably talk about that. I will help you. But there is a way out, and it's a collection protocol, and it is training, and it is insurance breakdown so that your team can estimate copays and foresee denials. By the way, in and out of network.
Perfect. All right. So to wrap up our discussion, let's talk about what success actually looks like when improvements are being made. Because practices often want to know what early indicators they should be watching for. So Tracy, how has the insurance landscape changed for dental practices over the last few years?
It's just become more confusing. So I think the biggest thing is all the relationships that all the insurance companies are creating with other insurance companies. All these, like 2025 was a huge year for this. So not only do we have our traditional umbrella networks, okay, and when I say an umbrella network, again, I know there's lots of terms for them, but I want you to think about this umbrella network is one contract, one fee schedule, and covers multiple insurance companies. Okay. There's pros and cons to umbrellas. That's a whole separate conversation. But there's also been all of these new arrangements that have popped up. So principal and guardian now share networks. They'll if you're contracted with principal, that can push over to guardian. Guardian has its own umbrella network. So Guardian, if you sign up with Guardian, you're not only in network with Guardian, but then you have all the, I don't know, there's like 20 something insurance companies underneath it. So now you're under that umbrella. United Concordia has one, United Healthcare has one, Principal has one, Ameritas has one. These were all things that didn't used to really be in play. And now there's more and more and more of that continue to show up. There are ways that you as a practice don't have to let this affect you. They're called opt-outs. There's ways, it's not like, oh, because they created this, you're automatically in. Okay, so there's opt-outs, but you have to do an opt-out. Otherwise, you're automatically in. So if we don't pay attention to the email that comes, or we don't get an email, we thought we got an email, who knows, or a piece of paper, again, this is how we talk about how our fee schedules start moving around and people are like, I have no idea what's going on. So the biggest change is for sure all of these relationships that are popping up. And like I said, there were another two that were just announced the other day. Cigna and Principal, I think, and maybe Cigna and Guardian. So they're all starting to intersect. And so here's the thought though behind it is the more that these happen, how many contracts do you need? Because now you have more reach with one contract. So that's, again, those are things that you might not need the 10 contracts you had before. Now we might only need 5, but that is definitely the biggest way. And it's hard. It's hard for all of us to continue to keep up on it, figure it out. I certainly don't know everything. But it's a challenge, and I would imagine that it's going to get harder before it gets easier.
Thank you, Tracy. Thank you so much for that insight. So, before we officially wrap up, just one final reminder. If today's discussion sparked any ideas around improving profitability, tightening systems, strengthening, collections, or identifying gaps inside the practice, definitely take advantage of the complimentary marketing strategy meeting from Equa Marketing. Again, the QR code is still on the screen, so feel free to scan it to schedule your complimentary session with the Equa team. Okay, so now we're going to open things up for our live Q&A. So if you'd like to ask a question, please drop it directly into the chat. and we'll do our best to, answer as many questions as possible before we wrap up. So we already do have a question from Sam. Let's see. So the question is, with regard to posting payments, what do you see as the biggest difference in accuracy between an experienced biller versus a novice appeals? So maybe we could start with Tracy.
Well, Bree, I feel like that's such a great question for Bree because it has to do with the claims. But and so Bree, I'll turn it over to you. The only thing that I would say about that is obviously an experienced biller is going to understand how to read the EOBs better than a novice. And you're open if that novice is not trained, there's more potential for error.
Yes, basically the same. My answer is basically the same. I think that the biggest difference that I've seen in practices that I've kind of done hands-on things with is usually the write-offs are too high or the secondary write-offs are messed up. That's probably the number one thing, actually. The secondary write-offs can be messed up. Sometimes the way that EOBs are written, they'll have like the co-insurance and the deductibles sort of like on different parts, and there's confusion about like, do I add them together? Do I not? So write-offs are kind of the number one issue. And then also the lack of appeals, like we keep going back to, is a big indicator because if they don't have the experience to know, like, this is something we actually could get paid on, all we have to do is send them more clinical notes, or maybe our clinical notes weren't effective enough in the first place, so let's fix that. Every issue that you see, go back to the root cause of it and then fix the problem from where it originates, and all of your systems will get easier.
All right. So we have one more question. So Tracy keeps mentioning competing contracts, umbrella versus direct. What do you mean by that? And how does MAP help?
So when we talk about competing contracts, the probably the biggest thing to think about is a competing contract can be, so for example, if we have a direct contract, so when we think of direct contracts, I want you to think of a one-on-one, okay? So if we have a direct contract with an insurance company that usually supersedes, and the reason I say usually is I feel like there's no 100% in any insurance plan, okay? So that usually will supersede any other arrangement that you have going on. So if you have an umbrella network, okay, so there's quite a few that are out there: Carrington, Connection, Dynamax, DHA, First Dental Health. It just depends on where you are in the country. Again, that is one contract, one fee schedule, multiple insurance companies. And so let's just say that you have an umbrella contract. We'll use the example of Carrington, and we have the example of them, and they you have also have a direct contract with Cigna. And let's just say that Carrington will cover Cigna. Your Cigna contract, because that's direct, your 1-to-1 ratio will always or usually supersede that umbrella. So sometimes that's how we talk about, no, those are competing contracts. Another way that contracts can compete are because of all these relationships that show up. So you can have it set with one insurance company, and the next thing that we look at, you got another insurance company that's fee schedule just popped right on in there. Now you have two competing fee schedules. And what happens when you have multiple fee schedules at one insurance company? Usually it's the lowest paying fee schedule that's going to win. They're not necessarily going to say, oh, you have this fantastic fee schedule over here. We'll give you that one, and we're going to not take this lower paying fee schedule over there. So you have to make sure that you don't have your contracts, again, competing with one another. You don't want to have too many fee schedules. So that's kind of the biggest thing, is you got to make sure that, again, all of those are buttoned up, so that you don't have that happen.
Yeah. So we're running a little bit out of time. I'm going to finish with one more question that we had from one of our registrants. How to get a hold of the insurance aspect, including codes, write-off, adjustments as a dental practice owner? Maybe Bree?
How to get a hold of it. I would say I would start with a simple audit and understanding yourself how what an EOB says. If you're the
Mm.
practice owner, then you can do quality control yourself if this isn't something that you can outsource. And even if you can outsource it to one of your team members, I still think spot checking it once in a while is a good thing. So, randomly, like pull up maybe 8 EOBs from the bigger claims, especially the more complicated ones, after they're posted and just see if they were posted the right way. And you can kind of see where your team might need training that way and see if they are flourishing or if they might struggle with the same thing. That example that I gave you earlier of the $50 and the deductible and the co-insurance being separate was from a coaching call I did recently because it was that exact issue. I was auditing EOBs and that's what I found. And these are simple things that our teams, they really care about being accurate, but sometimes the details just get a little muddy and they need a little help.
Mhm. All right, thank you so much, Bree. Um, okay, so as we begin wrapping up today's session, I also want to share one additional resource that could be really valuable for many of the practice owners joining us today. So, a conversation like this gives you ideas, insights, and strategies, but the real impact happens when you begin consistently applying those ideas inside your practice. And that's exactly where Dental Member Network or DMN comes in. So, DMN was created to give dental practices ongoing access to expert guidance, practical systems, operational support, and the real business resources designed specifically for dental practice owners. So inside DMN, members receive 24/7 access to expert guidance, vendor savings, monthly live AMA sessions, and a curated content library filled with training, templates, SOPs, and scripts that practices can immediately put into use. So one feature that really stands out is that members can actually submit business questions directly to vetted advisors and receive a written action plan within 3 days. So whether you're navigating insurance challenges, operational systems, profitability concerns, growth planning, or team processes, the goal is to give practices ongoing support beyond just a single event or webinar. You'll also receive access to today's recording along with additional expert created resources and implementation tools. So the waitlist is officially open now at dentalmembernetwork.com. Once again, dentalmembernetwork.com. So the first 100 founding members, the rate is locked in at just $49 per month for life. So you can simply scan the QR code on the screen or use the link that will be placed in the chat. Definitely take a look while spots are still available. So, as we wrap up today's discussion, I want to say a huge thank you to Bree and Tracy for sharing their expertise and insights with us today. And of course, thank you to everyone who joined us and spent part of your evening with us. We hope today's conversation provided practical ideas that you can take back to your practice and begin implementing right away. So, before you leave, I do have two quick reminders. First, if you haven't already scanned the QR code, I'd strongly encourage you to take advantage of that complimentary practice growth session from Equa Marketing. And second, we'd really appreciate it if you could take a minute to complete the feedback survey that will be shared in the chat. Your feedback helps us continue improving these events and bringing you valuable education content in the future. Thank you again, everyone. We really appreciate your time and we look forward to seeing you at a future Thriving Dentist Expert panel. Have a wonderful evening.
Thank you.